Good afternoon. Let me introduce my PhD topic, which is control of fear memories and management of dental anxiety. I'm Ábel Major, a first-year PhD student, and my vision is less anxious patients in the dental office, and my mission is to provide data for policymakers to create guidelines. I have several ongoing projects. Let me introduce my first one, which is investigating the efficacy and safety of pharmacological interventions on anxiety in patients undergoing dental treatment. Who is anxious about their next dental appointment? Who has a friend who is afraid of dentists? In this project, we are examining what can we do about this. Dental fear and anxiety is when unrealistic negative emotions associated with dental treatment. It affects around 150 million people in Europe and US together. If a patient has dental fear and anxiety, that can mean that they visit us less often or not at all. Some patients can't open their mouth in the dental chair, which is a huge problem because it can lead to untreated dental condition, which affect not only their oral cavity, but their overall health. What can we do about this? We have different psychological interventions, behavioral therapies, and also pharmacological interventions. Let's focus on these. We have benzodiazepines, which are potent drugs, but they have notable side effect and addiction potential. We also have herbal extracts, like valeriana or passiflora, which can be effective as well. Our aim here is to find the most effective and safe management methods for dental fear and anxiety. Our clinical question is the same. We would like to investigate patients undergoing dental treatment, different pharmacological interventions compared to placebo or to each other, and our main outcomes are anxiety scores or sedation scores. We would also like to investigate physiological state anxiety, like blood pressure or heart rate. We would like to also investigate side effects and safety profile listed on this slide. Our hypothesis is that benzodiazepines and herbal preparations can both effectively reduce dental fear and anxiety, but the latter have better safety profile. The implication for this research is that if we can effectively reduce dental fear, we can provide the patients the treatment that they need. They will have better cooperation during the treatment, they will have better satisfaction at the end, and also it means less complications for them. We designed a two-domain search key. The first domain focuses on dental fear and anxiety, and the other one is about pharmacological interventions. We identified around 1,300 hits, then after the title abstract selection is still above 700 randomized controlled trials. So we decided to split the project into a non-invasive method part and into an invasive and inhalation methods part. So regarding the progress, first I would like to show the non-invasive methods, which were further divided into a children part and into an adult part. For the adult project, the data extraction is done and the figures and tables is almost done. For children, the data extraction is almost done and the figures and tables are on the way. So let's imagine an intervention as a dot, another one as a different dot, and lines connecting these dots are studies investigating and comparing them. Using this, we can build a network. This network is only about non-invasive methods for adults. This is a really complex network, and I would like to break it down for better understanding. So we focused on the most studied interventions, which is midazolam compared to placebo. On this forest plot, you can see an effectiveness outcome, which is number of calm patients during surgery. Here we compared midazolam to placebo. In this forest plot, you can see risk ratios, and the heterogeneity during the studies were low. The overall effect is 1.6, meaning a 60% increase in number of calm patients during the dental treatment compared to placebo. So we can say that midazolam is an effective drug to reduce dental fear and anxiety. However, this result is not statistically significant, so we need more studies to further specify this outcome. Now let's expand our knowledge about the drugs we use. In this part of the network, we can say that we investigated midazolam to herbal preparations as a network meta-analysis. So we investigated 3 types of herbal preparations, which were valeriana, passiflora, and erythrina, to each other, to midazolam, and to placebo. In this forest plot, you can see risk ratios, the same outcome as before, the number of COM patients. Here you can see that the risk ratio ranges from 1.3 to 2.2, meaning at least 30% increase in number of COM patients during the dental treatment. The most effective drug was midazolam and passiflora, but valeriana has moderate effect as well. Erythrina can be a good option, but this result was not statistically significant, meaning that we need more studies on these drugs. Now we have seen that these drugs and herbal preparations can be effective reducing dental fear and anxiety. Now let's focus on their safety profile. We investigated an adverse event, which was sleepiness after the treatment. Here you can see 2 subgroups. The first one compares herbal preparations to midazolam. Here you can see that the risk ratio was 0.65, meaning 35% decrease in number of reported adverse events, which was sleepiness after the dental treatment. The heterogeneity was low, meaning that the results are consistent through the studies. So after we examined the herbal preparations compared to placebo, and we found that the risk ratio was 2.44, meaning that more than 2 times increase in the number of adverse events. However, the heterogeneity was high, and we have low number of studies, so this effect is uncertain. I would like to introduce my next project, which is a Eurostat project about microdata. We also would like to investigate anxiety in adults and the connection between the dental visits and the use of dental care. We know from previous studies that there is a correlation between general anxiety and dental anxiety. So our clinical question here is that, is there a difference in dental visits among people with or without chronic anxiety? We would like to investigate data from different age groups and population with chronic anxiety, with medication or without medication. And the comparative group is healthy controls. Our outcomes are dental visit numbers and expenses for dental care. So our hypothesis here is that people with chronic anxiety visit dentists less frequently, but those taking medication for chronic anxiety visit us more often compared to non-medicated patients. So the clinical implication for this research is that if we can effectively manage chronic anxiety, that would mean their dental anxiety will be less, and they can have the dental treatment if they are properly medicated. So right now we are doing the ethical approval of this project and did the data retrieval proposal. So now we are waiting for the data to arrive. I also have another Eurostat project, which is also investigating chronic anxiety and depression, but in this study we would like to associate the anxiety with pain and the use of non-prescribed medicines, which is a little bit different from the previous project. This project is also in the same phase, and we are doing the ethical approval. So I would like to summarize my project. The first one is about dental fear and anxiety and its possible pharmacological management methods. My last 2 projects are Eurostat projects, which is also investigating anxiety and dental care. So I would like to end my presentations with the words of Albert Szent-Györgyi. A discovery is said to be an accident, meeting a prepared mind. So thank you for your attention.
Thank you for the very interesting talk. I wonder, do you have any experience with how the drugs that you've presented in the first project affect the cooperation with the patient, and does it take longer to treat them, to give them to treat them against caries?
So unfortunately, we don't have any data on these cooperation only for children, but we have treatment times, but we didn't find a significant difference. Because when a patient is so uncooperative, they try to do other sedation methods in big centers, and they somehow choose a specific population which can be treated, but not that seriously anxious patients.
Thank you.
Any other questions from the floor? Okay, so it's easy to understand how you are going to dose the midazolam, but how about the herbal drugs? How do you do that? How do the literature deals with that?
So it's really hard to tell, because most of the drugs were they specified how many herbal extract they have in the tablet or the capsule, but we don't know the exact composition of this extract. So we can say that we have standards for extraction, but those were not really reported here. But the doses were almost the same through the studies. So they say they use a standardized extract, but we don't know what standardized that extract.
What do these articles recommend to use vital sign monitoring during these treatments, or you don't need that?
I think for those studies, they all used vital sign monitoring. Most of them recommend using when you use the drug as well, but when we are realistic, we can say that some of the drugs are over-the-counter drugs which can be used by anyone. So it's better to have at least an oxygen saturation monitor, but I wouldn't say that we recommend.
Well, midazolam isn't exactly over-the-counter, but in a country like Hungary, about 1/5 of the population is popping some kind of VZD. So did you take that into consideration in your study, that people are already taking it regularly?
Unfortunately, we don't have studies on that. Those who were included in these studies are completely healthy individuals, except the anxiety, and they are non-medicated for that anxiety, as far as I know.